and I'm very happy to be in this session. Thank you.
Good afternoon, everyone. My name is Naura Samar, emergency medicine resident, currently doing my year 4, and also one of the emergency medicine chief residents. I work at the home hospital, and my interest, I mean, it will be a long list, but I would say, I mean, one of them is critical care in the ICU. And it's my pleasure to join you here in the discussion today.
Good afternoon. My name is Shamma Al-Hajri. I'm a 6th-year medical student. My interest so far is like in internal medicine and pediatrics, and everything else is interesting, but I'm still looking forward to other rotations.
I'm Aisha Al-Bahri, 6th-year medical student from UAEU, and I'm interested in cardiology. Shall we start?
Yes, so shall we start, guys? So we'll start with the scenario. So Aisha and Shamma, you're ready?
Yes.
Okay, beautiful. So we'll start with the scenario. So you have a 45 years old female brought by EMS, actively seizing. They reported a history of multiple seizures over the past 15 minutes. She received 3 doses of IM lorazepam 2 milligram. The last dose was less than 1 minute ago. So the patient is currently in recess. Any questions you want to ask at this point?
Did they... go ahead, Aisha.
Is the patient known to have seizure, like epilepsy?
She's non-epileptic, yes.
Okay. And she's on medication?
We don't know.
Oh.
Did they check her oxygen saturation and like her ABCs?
Good. So you mean the vitals? So yes, I mean starting 95 on nasal cannula, temperature around 37, vitals 180/70 blood pressure and 115 heart rate. Respiratory rate is 15. This is the latest vital. Anything else you want to ask? So you asked about the background of the patient. I told you epilepsy and also hypertensive. Vitals you asked about. Anything else you want to ask?
Before the occurrence of this seizure, were there any symptoms or like?
We don't know actually. So I mean, at this point, since your patient is being transferred from the stretcher to resus bed, you have almost 1 minute to ask the history, and especially they gave her IM lorazepam less than 1 minute ago. So you can just spend 1 minute asking the EMS some of the important, pertinent questions. So among the question you asked, anything else you want to know?
Is she pregnant?
We don't know. All right. So, I mean, at this point, some of the pertinent question would be, as you guys mentioned, vitals you want to know, background of the patient, symptoms onset, description of the movement and nature of the event, and the duration, types of movement. Is it generalized? Is it focal? And one last important question is, did the patient achieve post-ictal or not during these multiple episodes? Okay, and we will talk about it, why we're asking this question. So, I mean, in a brief, they brought the patient from home. They gave history that the patient collapsed almost more than 1 hour. She called her friend to take her to the hospital. Then her friend came to her house, found her collapsed, and called the EMS. So in the EMS, during the 15 minutes transfer, she seized, I mean, multiple episodes. but they gave her three shots of IM lorazepam, 2 milligram, which did not work. Still patient actively seizing, and now the patient in resus bed. So we spoke about the points in the history that you might want to ask. Obviously, I mean, we shouldn't waste a lot of time here, but since we are discussing this case, and we will be going slowly and break it down and analyze it. So if you had this history, that would be amazing. If you could not, the EMS, they don't know, you should proceed, right? So you should assign maybe your team. That would be the next step, correct? So in terms of team preparation, what are the things you want to consider? How many nurse members you need?
We need a nurse to monitor the vitals, like there, and someone to hold the patient while while she's seizing.
What do you mean hold the patient?
Because the patient should be set on the left side.
Excellent.
Like,
okay.
laterally.
Okay.
They might have. She might have the tonic-clonic jerk movements. So we should stabilize her so she doesn't fall or injure herself.
Beautiful. So you said one nurse. Okay. How many nurses in total you need? One, two, three, 5.
Maybe 2.
Excellent. Yeah, I would say, I mean, at least 2 or more. So, I mean, one nurse can handle the airway, can suction, can bring you the adjuncts, reposition the patient. Also, the other nurse will be on the line, right? You need somebody to try to obtain the line, which will be challenging in this case, correct? So in that case, you might need 1 or 2 nurses on the line, so one can collect the blood, one can fix the hand maybe, send the labs, administer medications. So all these things will determine, I mean, how many nurses you need at this point. So I would say 2 or 3 at this point would be enough. And obviously, this patient has to be in the resus, so you need an equipped resus bed. Okay. All right. So you set your team already, and the patient is in at the bed already. So what is your, I mean, next step?
Maintain the ABCs. Like
Excellent. Okay. So what do you mean ABC?
So we should check the vitals again, make sure that the airway is patent.
So before you go to the ABC, your patient is actively seizing. Do you wanna consider anything at this point before going to the ABC?
Can we give lorazepam again?
Excellent. Yes. So I mean, you are trying to give the lorazepam, but you don't have a line or IV access.
We can give rectal diazepam or again intramuscular.
Yes. Yes. So for intramuscular, as per guideline, they suggest midazolam would be a better option. Okay. And the dose would be based on the weight. So if it is more than 40 kg, you can go ahead with 10 milligram IM midazolam. Okay. If it is less than 40 kg, you can give 5 milligram midazolam IM. So this is one of the routes would be IM. What other routes?
There's buccal and intranasal lorazepam.
Okay. So intranasal, yeah. Buccal, I mean, maybe it will be difficult. Patient is actively seizing and clenching mouth. So, I mean, any other routes that we sometimes use in the ED if there is no IV line would be the next. You mentioned also PR, but what else? How about interosseous? So we can administer 4 milligram lorazepam interosseous. So, I mean, your alternative in case of there is no IV access in a patient who's actively seizing would be either IM or IO. Okay. PR, we can try it, but I believe IM or IO would be the fastest routes for drug administration. Okay, so Midaz IM or Loraz IO, 4 milligram. So after your intervention, the seizure aborted. Okay, you gave IM lorazepam 10 milligram, and the seizure aborted. Okay, so now you can proceed to the primary survey. What do you want to check in primary survey? Can you conduct a primary survey?
So first, the airway.
Excellent. What are you checking the airway?
Is the patient speaking? And the
patient is not speaking. Patient seizure just aborted, okay. And the patient is let's say somnolent. But I can tell you airway intact. There is some oral secretions in the mouth. Also, upon inspection, there you note that there are two small lateral tongue bites and lip bites with minimal bleeding.
What about her oxygen saturation?
Oxygen saturation 91% on nasal cannula.
Should we give the patient oxygen mask at this point?
Okay. So, yeah, you give the order to the nurse. The nurse put how much flow you need?
I don't know.
Okay. So let's say, maximum flow, which is around, 10 to 15 liters. Simple face mask. Okay. Sometimes in ED setting, when we see such patient, we put her on nano breather. Okay. Anything else you want to consider in terms of airway?
Ventilation, the CO2 levels.
What do you mean by ventilation?
Yeah, if the patient is breathing, we see their chest expansion.
Yes, so now you want to move to B. And A, you wanna do anything at this point in a patient who just seized and drowsy. So you should consider protecting the airway, right? So how you can do that? At this point, maybe you should think of airway adjuncts. Okay. So what are the examples of airway adjuncts?
Oropharyngeal or nasopharyngeal?
Excellent. So maybe NPA would be better option in this patient. So you go on and put an NPA. What else? You mentioned earlier repositioning the patient. So what is the safest position in this patient?
Lateral.
Excellent. Why? So, we put the patient on lateral position to avoid aspiration, vomiting, and they might develop, aspiration pneumonia later on. So lateral position would be a safe position who's for a patient who was seizing or expected to seize again. Anyways, so far, you mentioned the important things in the airway. You put an NPA, you put her on a face mask or non-breather. You want to move on? Or you want to add anything in the airway?
Move on.
Okay. So what is next?
Breathing.
Yes.
So we can inspect the chest for rising symmetrically, and we can auscultate and do the percussion.
So, you do these maneuvers. You note that there is no apparent respiratory distress. RR around, let's say, 14, 15. Bilateral good air entry with some transmitted sounds. Saturation 95 on face mask. Happy?
Yes.
Okay. So you want to carry on?
Yes.
Okay. What do you want to do next?
We will check the circulation.
Yes. What are we checking in circulation?
Blood pressure and heart rate.
So
The
blood pressure around 190 over 180, 190 over 90. You said heart rate?
yeah.
So 115 heart rate, regular tachycardic. What else?
If there is any cyanosis, peripheral cyanosis, how is the skin? Is it cool, warm?
So extremity is warm. Capillary fill is normal. Any critical action you want to do at this point?
IV access?
Exactly. So you want to go for two. I mean, optimally, two large balls. Optimally. And what else? Another critical action here.
Draw for some blood test.
Yes. So draw blood test. Okay. What else?
Can
Apart
we
from the IV access, anything critical here?
can we give a fluid?
Maybe you can give. Yes. What else?
I have a question. The blood pressure,
Sure.
should we lower it now? يعني give the patient something to lower the blood pressure?
So I would suggest, I mean, complete your primary survey. Okay. It's not recommended at this point to lower blood pressure until you know what's going on. So obviously, for example, if you're talking about other patient who is non-hypertensive, he's, I mean, clinical stable, awake, you can lower the blood pressure. But for a patient, you don't know, you need to know what's happening first and what's the reason for the high blood pressure before you think of the management and lower blood pressure at this point. So, I mean, as part of the, I mean, your primary survey, obviously this patient has to be on what type of monitor, regular monitor or cardiac monitor?
Cardiac monitor.
Exactly. So this patient has to be cardiac for two reasons. The first reason, this patient can deteriorate due to his primary clinical condition or primary disease. Okay. Or it can be, I mean, he can deteriorate as part of, I mean, your medications, your intervention. So this patient is a critical patient and he has to be connected to the monitor. Okay. So in terms of C, you guys are happy or you want to do something else?
I think we're good to go.
Okay. What else? What do you want to do next?
Maybe check the limbs for injuries, like because of the seizure.
Okay. Maybe you can do it now, or this can be part of the secondary survey. So obviously, I mean, there is no, as part of the C, there is no obvious bleeding. Okay. So after C, what comes? This is part of the primary survey. So A, B, C, what else?
D.
Okay. And D, what are you checking?
Glaucoma.
Yes. So, I mean, what elements you want to check in glaucoma? You can ask me and then I will tell you.
Okay.
So we have three elements.
Eye, verbal matter.
Okay. So for eye, your patient, I mean, you can see just minimal eye response to pain. What else?
Speaking. Is the patient speaking? No.
You can hear some sounds there.
Okay. Sound.
What
And
else?
what about the motor? Is the patient?
So when you try to elicit motor response, I mean, the patient, you get the only response you get is withdraw from pain. Can you give me a rough estimate for the GCS now? So you had three elements. So your patient eye response to pain.
Okay.
Some sounds are there and some withdraw to pain.
4, 8.
Excellent. Yes. So GCS 8. What else? In D, what are we looking for in patient with seizure? This is a critical point here. Okay, so you want to consider checking the glucose at this point?
Yeah.
Yes. So as part of the D, you can do a rough GCS estimate and along with the glucose check. Okay. So while you are doing your primary survey, your patient started to seize again. So what is your intervention now? And the nurses, they already have IV access.
IV lorazepam.
How much?
10 milligram.
How much?
10 milligram. I don't know what the
Yeah, no problem. So you ask your attending and he tells you, yes, you can go ahead with 4 milligram. So, I mean, we can use either lorazepam or diazepam, okay, as IV route. What we prefer here in the recess, we use lorazepam. For lorazepam, there are two approaches. One approach, we go with 2 milligram and we repeat it after every 2 to 3 minutes. And some doctors, they go with 4 milligram and they repeat the dose if needed after 5 minutes. Okay, both are fine as per guideline. So you give, how much you want to give? 4 milligram lorazepam?
Yeah.
Okay, what else? So now, so far, you have completed your primary survey. What are your interventions? So I told you your patient is seizing. You gave the benzo, which is 4 milligram lorazepam. Okay. What other intervention you want to consider at this point? So in terms of seizure management, we have the benzo and what else? Anti-epileptic, صح?
صح.
So, I mean, any idea, any options? Do you remember any anti-epileptic options?
Valproic acid, levetiracetam.
Excellent.
Those what I remember.
Okay, and one more thing, which is the phenytoin, صح? Phenytoin or phosphenotoin. So you might consider loading the patient at this point, okay? Especially this patient had multiple episodes of seizure. So, I mean, among these three options or four options, so we have phenytoin, phosphenotoin, Keppra, which is levetiracetam, and valproate. I mean, as per guideline, they prefer phosphenotoin over phenytoin because it's water soluble, less skin irritant, and it can be infused faster. Okay, because bear in mind, all these anti-epileptics, you cannot infuse it fast. It has to be done over, I think, minimum 20 minutes. Okay, so but for phosphenotoin, you can infuse it over maybe 10 minutes, 10 to 15 minutes. But always when you give the phenytoin or phosphenotoin as part of the side effect, you might expect hypotension, arrhythmia, AV blocks, fibrillation. That's why, again, this is the reason for considering cardiac monitor from the first go for such patients. Okay. Sometimes in the recess we consider Keppra because it has a safer side effect profile. It is safe in patient with liver failure. It has safer hemodynamics. That's why we go with Keppra, 1 to 3 grams. You load it over 15 minutes. Valproic acid, yes, it's one of the options, and but you should avoid it in a patient who are known to have liver disease or in liver toxicity. So in such case, you can go with either Keppra, phosphenotoin, valproate. It's up to you. So let's say, I mean, in recess, we loaded the patient with Keppra, 1 gram, and you give your lorazepam, which is 4 milligram. Okay. You sent your order. So your nurse asked you what kind of investigations you want, doctor.
We will ask for the CBC.
Excellent.
يعني to look for inflammatory marker يعني the white blood cells. Also the toxicology screening and electrolytes also.
Okay. What else?
In female patients, we would like ask also for the testing for pregnancy.
Excellent.
PTSCG, because we could يعني think about eclampsia caused seizures.
What else?
VPG.
Excellent. Blood gas. What are you looking in blood gas?
Any acid-base abnormality, lactate.
Okay. What are you expecting?
Acidosis, like lactic acidosis because of the seizure.
Excellent. Yes. So, okay, what else? Anything else you want to consider? Patient with status epilepticus?
CT.
Yes, but I mean, at this point, maybe you wanna. I mean, you might consider it afterward. Okay, but yes, brain imaging. What else?
Alcohol blood levels, maybe.
Okay, so you said tox screen, urine and blood. What else? So as part of the workup, when I was talking about the medication, you want to send for LFTs, right? LFTs, coagulation. So, I mean, these labs you are sending should be based on your differentials, right? So, I mean, in this case, what are we talking about? So, what type of seizure are we having in this patient? What in this patient?
Generalized seizure.
Okay. Anything specific to it?
It's complex. And it starts epileptus because
Exactly. Excellent.
the time.
So what's the definition of status epilepticus?
Seizure lasting يعني was it more than 5 minutes and not resolving, or multiple seizures followed by each other without an post-ictal state or recovery. I don't remember exactly.
Yes. So exactly. So it's either single seizure more than 5 minutes. Okay. So this is the definition of the status epilepticus. Either a single seizure more than 5 minutes or multiple seizures without regaining full consciousness between these episodes. Okay. So if you remember, part of your questions to the EMS was did this patient achieve or regained full consciousness between episodes or not? Okay, so the patient did not achieve full consciousness. Okay, so yes, we are talking about status epilepticus. So what are the causes or differentials? Because this will guide the orders you place or the orders you ask the nurse to send. Okay, so what are the differentials of status epilepticus? What are the causes? Bear in mind that sometimes, I mean, the causes of seizure and status epilepticus, they overlap, okay? So you can think of both. What are the causes for seizure and what are the causes of status epilepticus?
A trauma could cause like a hematoma or something.
Oh, okay. And maybe that's why you want to consider brain imaging later on. What else?
Hypoglycemia, hypocalcemia.
Excellent. Okay.
Infection.
Excellent.
Brain tumor.
Yes. What else?
Overdose.
Mm-hmm.
Maybe.
What else?
Eclampsia and pregnancy.
Excellent. What else?
Unknown also.
You mean idiopathic?
Yeah, idiopathic.
Okay, maybe. It might cause, I mean, episodes of seizure, but maybe not status epilepticus. What else?
Electrolyte imbalance.
What type of electrolytes?
Sodium and calcium and magnesium.
Okay, excellent. What else? So if I tell you this patient is non-epileptic, anything you want to consider part of the your differentials that you formulated?
Their response to the medication that they're taking now, like their anti-epileptics, maybe they're not working anymore. So we have to adjust the dosage and all that.
Yes. And what else in addition to the I mean, yes, the drug might not be working, and they need either dose modification, and what else? You should consider non-compliance as well. So you have to ask about it. Is the patient taking the medication or not? Okay. طبعا obviously if you have a good collateral history, you should ask all these questions, okay, which we'll cover later on. But for this time, for time being, I mean, you are just formulating your differentials. You are not sure I mean, what is the cause for your status epilepticus at the time being, okay? That will come up as you move on to the, I mean, to the next survey, to the secondary survey, right? So based on the, I mean, differentials you mentioned, I mean, it could be vascular related. You said, I mean, trauma maybe, bleed, hypoxia, hypoglycemia, infection, encephalitis, abscess. It can be structural brain issues such as, I mean, tumors, meningiomas, metastatic cancer. It can be also related to metabolic electrolytes, tox, withdrawal, trauma, and non-compliance. So this is, I mean, a sort of, I mean, a short list for your differentials, okay? Because without differentials, you cannot approach your patient correctly. So you have to have first differential in your mind, and based on that, you send your investigations, okay? So you sent your investigations, which are CBC, electrolyte, blood gas, beta HCG, tox, anti-epileptic maybe level. You should consider it if you know the drug. Okay, if you know this patient on Keppra or phenytoin, you might think of the level. You should also send for coagulation and LFT because the coagulation you think of maybe if it is brain bleed or if the patient on any anticoagulation that you think of reversing it or correcting it. Also, you should send for the other electrolytes such as magnesium, calcium, and phosphate in addition to your regular electrolytes panel. So, I mean, at this point, I think, I mean, what we were discussing the intervention after your primary survey, okay? So you obtain your IV access, you should, so we'll start with the airway. Airway, you should do suction, positioning, consider inserting NPA. Also in C, you should consider inserting 2 large bore cannula. This is a critical, you must do it, and send your labs based on your differentials. At this point, since your patient is seizing multiple times and you already administered your second dose of lorazepam, you should think of loading the patient with antiepileptic because your goal is to abort the seizure as soon as possible. The more time you wait, the more the seizure will be refractory, okay? So that's why you should consider your antiepileptics and your benzo, okay, at this point. All right, so you did all these critical actions, okay, after your primary survey. Now, do you happy to move to the secondary survey or you have any questions?
Doctor, I don't know if it's related to the primary survey, but should we ask the patient if she has cardiac medical history or anything
Yes.
before?
Of course. So you have to obtain as much history as possible. Okay. But the problem here that the EMS, they brought the patient, there was no collateral history. They took the history from her friend, which did not come to the hospital. Okay. So the history, all the history that you have is that this patient collapsed almost 1 hour ago at home. And she had multiple episodes of seizure. She's non-hypertensive and non-epileptic. Apart from that, you don't know much. Okay. But yes, we will revisit what history elements you need to ask about in case the patient is awake or if there is a collateral history. Okay. So now, I mean, since there is no collateral history, we should not waste time. We should move forward, okay, and try to hunt for the clues, okay, based on your physical examination finding, your primary or secondary survey, okay.
Okay.
So now you did your primary survey, you did your intervention after the primary survey. What do you want to do next?
Reassess the patient vitals.
Excellent. So yes, so you ask the nurse another set of vitals, okay. So in terms of vitals, now your patient is saturating 95% on non-rebreather. Heart rate is 60, 59 in that range. Blood pressure is 160 over 90, okay. Respiratory rate is, 10. Temperature 37. Anything rings a bell here?
Can we consider intubation?
Huh?
Can we consider intubation?
Intubation?
Yeah.
Yes, you can consider it at this point. However, I mean, maybe do you want to proceed and do a quick secondary survey?
Yeah.
And then tell me why you want to intubate your patient after that, okay? So this is the vitals. You want to conduct a quick secondary survey, okay, to try to gather any clues. And after that, you can do your intervention, which is whatever you mentioned, intubation or whatever. Of course, I mean, obviously, at this point, your patient RR is 10, saturation, I mean, borderline 95 on non-rebreather. So in terms of intubation, maybe you should also alert the nurses that we might think of intubation, prepare the equipment. However, I mean, for the sake of discussion, I would like you to move on to the secondary survey.
Okay.
Yes. So in the secondary survey, what do you want to do?
Head to toe exam.
Okay. So in terms of examination, what do you want to do? Can you elaborate on the elements?
So first we start with the pupils.
Good. Pupils, yeah.
Yeah.
So you asked about the pupils. So you examine the pupil. Right eye, you know that the pupil is around 5 millimeters, non-reactive. Left eye, the pupils is 4 millimeter, minimally reactive. What else you want to examine?
Can we reassess the Glasgow Coma score again?
Okay. So for this patient, the Glasgow scale, I mean, for eye, the minimal response to pain. Verbally, none, no response. Motor, minimal withdrawal to pain as well. So if you, I mean, GCS at the time being maybe around 7.
Okay. Then can we auscultate for the chest and heart sounds?
So you do the rest of your examination, it's unremarkable. So you know these findings, okay? For, I mean, generally your patient is still somnolent. I told you the eye findings. Breathing is slow and irregular breathing pattern, around 10. GCS 7, okay, best response is 7. So at this point, what do you want to do?
Intubation.
Excellent. So the intubation, I mean, the decision to intubate this patient at this point is very important because this patient can crash. And based on the vitals, do you sense any specific thing based on the vitals? So I told you the vitals. Heart rate is 56, 58. Blood pressure 160/80 or 90. RR around 9. Temperature 37. So when you look at these vitals, is there anything specific? Does it ring a bell?
The respiratory rate
Okay.
and the heart rate.
Okay.
They're decreasing since the first assessment.
Excellent. So, I mean, based on the heart rate, RR, and blood pressure, is there do we call this? I mean, the bradycardia, hypertension, and bradypnea, and the respiration is irregular. Is there anything specific in your mind that you want to consider as a finding or as a sign?
Overdose?
Maybe, but what else?
Intracranial pressure.
Excellent. Excellent. So what do we call this? So you're suspecting high raised ICP, right?
Yes.
So what do you call this? Have you heard of Cushing triad?
In trauma cases, yeah, I think. Before.
Yes, it can be trauma cases or it can be in, I mean, non-trauma cases as well. So what is it? What is Cushing triad?
The bradycardia and hypertension and loss of consciousness. I'm not sure about the last one.
Yeah, so it's a triad, okay? It's a bradycardia, bradypnea, and hypertension, okay? So this triad, we call it Cushing triad. It's an ominous sign for brainstem compression due to high ICP, okay? So when you see these parameters, I mean, it is very concerning, okay? That's why after when you said intubation, after I told you the set of vitals in your secondary survey, it is definitely the correct action at this point, okay? But I just wanted you to complete your secondary survey so I can tell you about the eye findings and the breathing so you can try to correlate, okay? So based on your secondary survey, we are preparing, yes, for intubation. We will talk about it. But based on this, what is your impression?
Is the patient going into coma or losing consciousness?
I mean, yes, your patient, I mean, this is from initially, but what, I mean, in terms of differential, what are you suspecting? Huh?
Tumors.
Okay, what else? So, I mean, tumors, yes, it can be, but the nature of the presentation of this patient was acute, right? Isn't it? So, patient collapsed suddenly at home and then brought to the hospital. So, the nature of the presentation is a bit acute, okay? So, does that ring a bell or, I mean, tells you something in terms of differential?
Subarachnoid.
Excellent. So, I mean, not necessarily subarachnoid, but yes, some sort of bleeding. correct?
Yes.
Yes, excellent. So that is the important differential that you should consider at the moment. Anything that acutely raise your ICP, okay? And one of them is definitely the bleed. What type of bleed? We don't know, because the history, I did not tell you the history. We don't know I mean, is it related to trauma? Is it non-trauma? What happened exactly? We don't know, okay? But at this point, yes, you should consider intubation. So when you consider, I mean, what are the things you want to, I mean, what orders you want to give to the nurse when you want to intubate? We will not elaborate on complete intubation procedure, but we'll talk about just critical action and which medication you will be using, right?
Yes.
Yes. So tell me, what do you want to tell your nurse? So in terms of medications, what medication do you prefer, whether for induction or paralysis?
Ketamine, propofol.
Yes. Okay. So, I mean, as you guys know, for intubation, we have you have to inform the nurse, you have to prepare your equipment, you have to go over your 7 or 8 Ps, okay? That we'll maybe discuss later on when you have your, workshops. But for time being, and when you want to consider intubation in a patient who had seizures and high ICP, there are certain medication you want to use, okay? So for paralytic and for induction, so for induction of intubation, you have four agents: etomidate, ketamine, midas, propofol. What you want to achieve in this patient, you want to decrease the ICP, okay, and you want to also use a medication that can work for convulsion also, right? So when you want to intubate this patient specifically, you want to use a medication that stops the seizure and reduce the ICP. All right. So among all the four agents I told you, which is, I told you etomidate, ketamine, midas, and propofol. Maybe you want to use propofol and midas. Okay. So both of them, maybe they can work on the seizure. They can, maybe reduce the ICP. Some people might consider fentanyl as well to reduce ICP. But I mean, for a patient with seizure, we go with either midas or propofol, okay? Or you can, use both of them as, small doses. In terms of dosage, for midazolam, it is 0.2 milligram per kg. For propofol, 1 to 3 milligram per kg. These agents as induction agent. For paralytic, we can use, they prefer for, if you are suspecting ICP, you can use rocuronium, okay? But some people, they use SUCs. So for rocuronium, it is 1 milligram per kg. For succinyl, it is 1.5 milligram per kg. If you are considering ICP, maybe you should go for rocuronium, okay, as per the studies and the guidelines. All right. So now you already told your nurses that you need midas and propofol, okay, and maybe rocuronium, and you already told them the doses. You are preparing for intubation, and your equipment is ready, your RT is ready, and without going to, the full details of intubation, you successfully intubated this patient, okay? So what is the next step you want to do?
You mean like the procedure itself?
No, I told you, patient already intubated, connected to mechanical ventilator. Okay. Anything specific you want to consider at this point?
Consult ICU.
Okay. Maybe it's a bit early, but yes, you can consult ICU because obviously this patient will land up in the ICU. Yes, but you are still with the patient. So, and you need to intervene. So you said intubation based on the Cushing triad. Yes, you intubated the patient successfully. You used your agents, and you put the patient on infusion post-intubation, maybe midazolam infusion and propofol. What else? So you're suspecting evidence of raised ICP. So there are some, I mean, yeah, some intervention that you can.
Do we do the neurological examination again?
Yes, you can do it, but it will not be much yielding. It will not change a lot of things. Maybe you will be finding some upper motor signs with the pupil findings, but I mean, it will not be yielding much. So you are suspecting there is evidence of raised ICP, intracranial pressure. Okay, so there are some intervention you can do to reduce the ICP. So part of the intervention, so at this time, you might consider as mechanical ventilation, you might hyperventilate, and also you might consider hypertonic or mannitol. And you should immediately send the patient to imaging, right?
Yes.
You need to scan the patient to know what's happening in the brain, right? There is the Cushing triad, and you don't know what is the exact cause. You are suspecting maybe there is bleed, okay, based on the nature of the presentation, but still you have to send the patient immediately. And obviously we did not send this patient before, because the patient his airway has to be protected, okay? That's why we intubated her, and then we are going to send her for CT. Meanwhile, there are some, I mean, measures that you might want to consider now or after maybe the CT, which include hypertonic saline or mannitol. You want to raise the head and hyperventilation. So anyways, you did, I mean, these things, and you sent the patient to CT immediately. So in the CT, can we see? Can we have the picture? CT scan picture. Do we have it? I think I sent it earlier in my document. Do we have it to show the CT scan or not?
It's on the screen already.
Yes, doctor, it's showing on the screen.
Because I cannot see it, honestly. Anyways, if everybody can see it, maybe you can comment on the CT scan. So Aisha or Shema, can you comment on the CT, what you can see?
There is hyperintensity on the right side.
Excellent.
The ventricles are compressed.
So what is this?
Is it intraventricular hemorrhage or subpleural?
Yes, it's hemorrhage, but it's not intraventricular. It is intraparenchymal. So you are right. It's intraparenchymal hemorrhage. What else? Do you see anything else? You want to comment on something else? So when you have a CT brain, what other things you want to comment on?
The midline.
Excellent. So is the midline okay to you?
I'm not sure, but is it slightly? I'm not sure if it's deviated.
It is actually deviated, yes. So midline shift. What else you want to comment on? I mean, that's obviously what is shown in the picture. Obviously, I mean, we had to take multiple sections to be able to evaluate the bleed and the other findings of the CT scan. But in this image, we can see right intraparenchymal bleed with midline shift, and maybe evidence of, I mean, subarachnoid bleed when you trace the falx cerebri. But I mean, it's very clear. because I'm telling you because it was in the CT report. So anyway, based on that, based on these findings, what do you want to do next? So you see this image, the CT image. So what do you want to do for this patient?
Consult neurology.
Okay, neurology.
Neurosurgery.
Excellent. Yes. So neurosurgery. Yes. What else? What other critical actions you want to do?
We use mannitol to lower the intracranial pressure, right?
Excellent. So if you did not use it, you can use it now. Yes. So yes, mannitol, or what else?
Acetazolamide, maybe.
Acutely, there is no rule for acetazolamide. Maybe hypertonic saline. So either mannitol or hypertonic, one of them. So for mannitol, you can give 1 gram per kg IV, okay? Or if you don't have mannitol, you can use hypertonic saline 3%, 100 cc to 200 cc as bolus over 5 minutes. Okay. What other intervention to reduce your ICP?
That we do in the emergency?
What is it?
Like we do it in the emergency?
Yes, acutely. So maybe some of them I already elaborated on, but I mean, let's wrap it up. So there is something called ICH protocol. Okay, so once you see, based on your clinical findings, based on your vitals, CT picture, you are suspecting this is, your diagnosis in intra parenchymal bleed and raised ICP. Okay. Something I also forgot to tell you in the CT report, there was evidence of right tonsillar herniation in this patient, okay? And in addition to the intraparenchymal bleed and midline shift. So based on this picture, there are some interventions that you have to do in the ER. You have to initiate in the ER, okay, until the neurosurgery comes and evaluate the patient and they decide what type of plan or surgery they want to undergo, okay? So part of this protocol, you said mannitol or hypertonic, okay? What about the head? So your patient is lying flat. Is that okay?
Their head should be raised to an angle.
Exactly. So around 30 degree, okay, head elevation.
Doctor, do we also induce hypothermia?
Hypothermia, no, we aim for normothermia. So hypothermia, maybe you are talking about post-cardiac arrest management. But for ICH protocol, we maintain normothermia and normoglycemia, okay? What else interventions? So you said head elevation, hypertonic, or mannitol. What about hyperventilation? Do you think it's useful here or has no role?
I'm not sure.
Okay, all right, fine. So part of the protocol is hyperventilation. What is the level of CO2 you are aiming for? We aim for 35. Okay, this is just these measures I'm telling you is a temporizing measure until you seek the final intervention for the patient, which should be surgery or what, based on evacuation based on the neurosurgical plan. Okay, so this measure, if when you see an ICH, you should consider which is head elevation, mannitol or hypertonic, okay, hyperventilation. You want to if your patient is vomiting or gagging, you should abort that with antiemetics as well. You should maintain proper sedation, okay? And given the fact this patient seized, or he was in status epileptic, she was in a status epilepticus, she should be on, sedation with propofol or midazolam. You should also aim for blood pressure control, which is, if this depends on the presentation. So if the presentation of the patient, what the blood pressure of the patient initially was more than 220, you aim for 160. If the initial blood pressure of the patient was trending initially between 150 to 220, you aim for 140. So to put it as a range, you should aim for blood pressure control between 140 to 160 in such patient with intracranial bleed. And as I told you, you have to keep the patient NPO. Okay. We already sent for coagulation, which was normal. But if there is any coagulopathy, you have to correct it as well. And of course, you have to consider neurosurgery consult and neurology consult for surgery and maybe EEG monitoring for this patient for any recurrence of the seizure. Correct? So I don't know if you guys do you have any question in terms of this protocol, ICH protocol, or it's clear?
It's clear.
Okay, good. So this protocol, you have to initiate it from the ER, okay? To try to salvage this patient, to try to salvage the brain, to reduce the ICP, and then you have to consult, as you guys mentioned, neurosurgery, immediate neurosurgery consult, and ICU consult, and you did the imaging, and you have to support the patient until the neurosurgery arrives and put their final plan on the patient. All right. So let's say, one last point I want to discuss, okay, is that let's say there is a collateral history, okay, because for you as a students, you have to know, what type of questions to ask, what important points to ask in the history, okay. So let's say, okay, let's assume that there was a collateral history. So what questions you want to ask?
Since when the patient is epileptic, and if they are compliant to the medications.
Excellent.
Any other past medical history, if they have this episode of status epileptics.
Okay, excellent.
Yeah.
Okay. Anything else?
I will ask if the patient had recurrent severe headaches in the past months and this day.
Okay.
Or a cardiac medical history. And I forgot, I don't remember it. كان في شيء في بالي.
Yeah. So what about the seizure? You want to ask about the seizure. So patient, when you see a patient in the ED with history of seizure, or he had an episode of seizure at home and they brought him to the hospital. Anything specific in terms of the seizure?
What happened?
Yeah.
What happened before the seizure, during the seizure, and after?
Exactly. Yes. So you have to make sure to cover the whole period. So you have to inquire about the onset of the seizure. Okay. So obviously, maybe the patient will not be able to tell you. He will tell you just suddenly I lost consciousness. But you have to ask the family members who was there with the patient and what did they see. So the questions you want to ask, I will summarize it. You have to ask about the onset of seizure. Okay. When did it start? The duration, and did the patient have any aura or any certain thing before the seizure? Any trigger for the seizure? And then you have to ask about the characteristic movements. Is it complete body, involving the whole body, or partial, tonic phase or clonic, or tonic-clonic. So based on that, you will be able to decide, is this partial, complex, simple, generalized, all these. Also, you have to ask about any incontinence. You have to ask about post-ictal confusion. Okay, and post-ictally, how was the patient? How did it take him to regain consciousness? All right, and any prior episodes. And is the patient, as you guys mentioned, on any anti-epileptic drugs, or any recent change in medications, or any non-compliance? And the previous, workup of the patient, if he has any, structural brain issue, any previous imaging, any intervention or surgery, any trauma, any admissions before, maybe to the ICU, or any history of, persistent seizure or status epilepticus. So all these, you have to cover them, okay, when you have a collateral history. Bear in mind that you always, in the ED, you take your history when time allows. If your patient needs intervention, you might postpone the history maybe to a later step, okay? But if time allows, your patient is stable, they brought him to the recess and he's vitally stable, there's collateral history, maybe you can dive more in the history, take further details, okay? This is basically the history taken. For your physical examination and seizure, what you have to cover is you have to examine, obviously, as you did, head to toe. You have to do a detailed neuro exam to try to elicit any signs if the patient is awake. If the patient is not awake, maybe you should aim for Babinski sign, reflexes, and pupils. Okay, or if you can see any certain posturing. And I think, once you cover these, and always put in mind the differentials. Based on your differentials, you have to guide your labs, your imaging, and your approach to the patient. So for you guys, so far, do you have any questions? So Shamman, Aisha, is it clear?
Clear, yes.
Yes. So this is a complex case. It's not straightforward, given the fact that this patient was non-epileptic. So maybe everybody would think that this patient is just a post-ictal seizure and maybe non-compliance. But still, I brought this patient to look. To always think about the red flags. Okay. So yes, you did not have enough history, but based on your findings, you were able to reach your sort of diagnosis, okay, and you were able to elicit your signs and look for the red flags, and based on that, you guide your management. So your history is very deficient here, whether by the EMS or by the fact there was no collateral history, but you guys were able to approach this patient and reach to the final diagnosis. So obviously, this patient was, admitted under neurosurgery and the ICU, and they planned the care accordingly. Obviously, this patient, due to the delayed course of, presentation, it has been, almost more than 1 hour. The patient was collapsed at home till the arrival to the recess. The outcome was poor, and the neurosurgery planned for just conservative management, and unfortunately, this patient, passed away after maybe 2 weeks. So, but the take-home message from this point is that the things we discussed. Maybe I can open the floor for Dr. Alpar, maybe to add any feedback, or to see how did we do in this case.
Doctor, I have a question.
Tell me.
And when do we decide to do the blood cultures, urine cultures in situations like this, where we cannot take history? And
Yes.
when do we do the ECG?
Yes.
Now or later? Okay.
Yes. So, I mean, I will answer your first question first, is that the blood culture. So part of your differential should be obviously meningitis, encephalitis, okay? You can send your blood culture if you're suspecting maybe fever and you're suspecting high WBC. But obviously to diagnose meningitis, you have to do LP, okay? Which is not possible with a patient who is actively seizing. So there are priorities, okay? If you are thinking that this is, yes, meningitis, you can go ahead, proceed with the antibiotics if the history and the picture suggestive of meningitis, okay? Maybe fever, patient was confused or altered for the past maybe couple of days, and etc. But if the patient is presented, I mean, in similar picture, you might, I mean, you might do the important action first, and based on that, based on the CT findings, maybe you will find abscess, maybe you'll find, if your CT finding is normal, you might think of maybe, yes, at that time maybe meningitis or encephalitis, okay, or maybe toxicology. So to diagnose, remember, to diagnose encephalitis or meningitis, you need LP, because blood culture might not yield much, and it will not tell you whether this is, I mean, CNS, there is CNS infection or not. So again, for blood culture, you go with the WBC, you will go with the fever, your history. This will guide you. What was the second question you asked?
When do we do the ECG?
Okay, that's a good question. So obviously this patient is seizing, so there is no way you can do an ECG for this patient. My question is, why do we need to do an ECG?
If they had like arrhythmia or seizure
Okay.
induced by cardiac, or maybe it's like a syncope episode. So
Okay, if we are thinking towards syncope episode, of course we have to do ECG. But for a patient who is who presented with status epilepticus, is there a rule for ECG or not? So the only time where you feel like you want to do ECG for this patient, if you're suspecting drug ingestion, okay, such as, for example, TCA tricyclic, you might find some ECG changes or arrhythmia that might guide you or help you. But for patient who is actively seizing, you might postpone the ECG for later. I mean, to just do the critical action first, and then maybe you can do the ECG when the patient stops seizing and when time allows. Is that clear?
yes, clear. Thank you, doctor.
Thank you very much. So thank you, Aisha and Shamma, for I mean, your approach for the patient, and I hope we covered most of the important points. However, I mean, we have to maybe to ask Dr. Arif if he wants to add anything to the case.
Sure. First of all, I really like the case. I agree, it's a kind of challenging case because the history of epilepsy before and coming with the new seizure again, and obviously our brains trying to think. Actually, we are trying to, grasp the pattern,
Yes.
and we can easily think that, okay, this is an old epilepsy patient, has already a seizure history, and therefore we want to think that way. But this case is excellent, how we need to think broadly to any undifferentiated cases. I really like the approach to our two students. Actually, they manage very well. And I
Yes.
actually specifically try to catch the critical actions they want to do. I think they did all critical actions in the case, and most of them were very timely. And then at the end, of course, their interpretation of the CT or the other results or the patient, findings. At the end, they didn't do anything harmful to the patient. So therefore, I think at this level, it's very nice management. It looks to me like this, and in a very nice case. Of course, I can talk a lot. However, I took some notes. Maybe I can go through those notes to give some specific things, and then maybe I can open the floor for discussion for a couple things. But first of all, I think it doesn't matter where you are in the pre-hospital, inside the ER, or inside the hospital ward. It does not really matter if you're exposing any undifferentiated case. So if you're exposing any undifferentiated symptom, situation, or case, I think it's always better to do primary survey, your critical actions, and then getting the fast, short history as best as you can, and going with the secondary survey and adding some other adjunct tests or imaging modalities. So this is actually standard approach for any undifferentiated case. Maybe most of you will not, expose the critically ill cases in the future, depending on your specialty. But believe me that even in that specialty, you will have some undifferentiated cases in front of you in one day. And don't forget your primary survey, patient's vitals. And when you see any abnormality during the primary survey, which is airway, breathing, circulation, disability, exposure, whatever. So you need to act and normalize those abnormalities in the primary survey as a critical action. And then, of course, you have to know some kind of information about past medical history, allergies, medications, or what happened, which this situation, happening now. So you want to know this. And please do not forget the, systematic evaluation of all cases, which is the secondary survey, and additional laboratory tests and imaging if it is necessary. So if you feel that way every time when you expose to any undifferentiated case, I think your approach will be very smooth, and you will be able to catch every abnormality that you need to intervene easily, and probably you will save many lives. Specifically for this case, if you guys a little bit, get the full screen of the case for me so I can see the details a little bit more, because I just see the secondary survey part. All right. I think in the primary survey, I think everything went very well. In the primary survey, when you do the disability, the general recommendation in trauma patients and also in the critically ill medical patients, yes, definitely we want to understand the mental status of the case, which is most of the time we use Glasgow Coma Scale. And in this case, you appropriately, evaluate the Glasgow Coma Scale and understand, what is the level. The other recommendation is checking the pupils immediately in the primary survey. Trauma patient or non-trauma patient, it doesn't matter. So why is this important? Because the pupils are one of the earliest, area giving the sign about the intracranial pathologies. Even the pupils can be acute each other, but a little bit sluggish light reaction should be warn you. Or any type of difference about the size in the pupil size should warn you. In this case, I think there was a 1 millimeter difference, and there is already obvious the light reaction, defect. So it could be actually maybe diagnosed in the primary survey, not in the secondary survey. I did understand the NAURAS actually forced you specifically in the secondary survey to look for it, but I think it could be better to look at it in the primary survey, and then you could understand, in the second minute of the patient evaluation, the primary survey, when you are doing the D, you will understand, okay, patient is unconscious, okay, it's actually seizing, yeah, maybe because of that reason. However, you have one major neurologic abnormality in the primary survey, which is anisocoria in this case. So in that moment, maybe your differential diagnosis may change a little bit, because as you said, intracranial hemorrhages can cause seizure, and intracranial hemorrhages can cause anisocoria if they are big enough, if they're increased, cranial pressure enough, or if there's any, shift So therefore, you can get this, the hint a kind of little bit earlier. But let's say in the primary survey, let's say there is no anisocoria, there is no light reaction deficit, or just you suspect something, but definitely pupils are equal each other. Okay, there is another way in the primary survey or after the secondary survey or after the primary survey as an adjunct bedside approach. And I want you guys to go and check for it. You can check intracranial pressure on the patient just by using the ultrasound. Just looking for the optic nerve sheath, for example, on the bedside. It takes 30 seconds to check. So therefore, maybe this can be another extra learning point for you. It's a very simple tool, ultrasound, on the bedside, and you can easily understand is this patient has an increased intracranial pressure or not. So what I mean in the disability in the primary survey now, your Glasgow Coma scale is very important. Your pupillary reaction and size is important. The third thing is important. I think it's better to look for is there any lateralized motor deficit on this patient? Of course, this patient is unresponsive, so therefore every motorized deficit can be understood by using the painful stimuli on the patient. So when you give the painful stimuli, you may understand that maybe patient, moving the left arm or leg a little bit less than the right side. So it can give you another clue about the intracranial pathology earlier in the primary survey. So I just want to stop here and ask you, is that clear, or do you have any questions about this approach in the primary survey?
Clear, Dr. Alper.
No,
And yes,
I know it's clear to you, but how about
students?
Is it clear to them?
Clear, doctor.
All right. So do these three things at least in the primary survey. Don't delay it. And you nicely check the glucose, which is very important. Every altered mental status case, whatever the cause is, always check the blood sugar. And then let me look at my notes. All right. And okay, before you move forward, if I remember correctly, the patient got 3 doses of 2 milligram lorazepam intramuscularly, right?
Yes.
Yeah, I think probably they did the intramuscularly because they didn't have IV access in the pre-hospital area. I mean, in the ambulance.
Yeah.
This is very difficult situation, really. I mean, I don't know how many of you had an experience to working in the ambulance or in the pre-hospital care environment. It is really terrible situation. I mean, patient is seizing, and of course, the patient relatives around you. As a paramedic, you can imagine that how stressful the environment, and you're not able to open any, IV line, and they prefer to do it intramuscularly. In the same time, maybe intraosseous can be open in the pre-hospital care, by the way. However, in any seizing patient, I think it is still a difficult procedure in the pre-hospital care. So in that case, I think trying to stop the seizure with the intramuscular with 2 milligram lorazepam, I think it's still reasonable. Yeah, we cannot say anything about it. So because there is no line any. All right, and then in the primary survey, you already opened the IV lines and monitorized the patient, and you prefer to give the lorazepam, if I remember correctly. Is that right?
Yes.
Yeah. I think this is the standard drug of choice now, almost maybe 5-10 years now. The lorazepam is the fastest affecting and almost the longest action drug in the benzodiazepine group. So it's a lorazepam is the right choice. As Navras already mentions, 2 to 4 milligram IV, you can choose it. If you choose the low dose, you can repeat 3 to 5 minutes. But if you choose, 4 milligram, for example, you can do every 5 minutes. But what is the upper dose of the lorazepam? Maybe we can discuss a little bit about it. There is no really consensus, but most of the authorities says that the 8 milligram, which is 2 times 4 milligram dose of lorazepam, it's a maximum dose you can think about in those seizing patients. It doesn't work. They said, add another drug and change another drug. And actually, you can combine the drugs even. So therefore, keep in your mind that after the second dose of 4 milligram, the lorazepam, you think that you don't need to give any more in the lorazepam. You just need to change the benzodiazepine type or add another, the drug in the second line treatment agents to stop the seizing patient. At this moment, I just want to criticize again about this patient. So imagine that the patient got already 6 milligram lorazepam, and you gave 4 milligram lorazepam, and somehow seizing stopped a little bit, and then start again, I guess. Obviously, patient seizing a lot, and you're repeating dose of the benzodiazepine, it doesn't work. So I'm questioning you now, our students. In that case, which secondary line agents you would like to add immediately?
Fosphenytoin?
Yes, it can be fosphenytoin, phenytoin, or now I'm going to ask another discussion actually, and if you have any idea, please go ahead and say it. So what they say, you're seeing a patient continuously seizing in front of you, and your goal as an emergency physician or as a primary care physician on that moment, to stop the seizing, right? We don't want to harm the patient anymore because of that seizing activities. So we want to stop the seizing, but patient still continuing the seize. You're stopping 1 or 2 minutes and he seizes again. And he never actually wakes up. So therefore, this is a status epilepticus. So understanding the status epilepticus and understanding your drugs doesn't work anymore after 2-3 trial. Some authorities again says that actually, you know what, it's better not to try any secondary line agent anymore. Go for and paralyze the patient, intubate the patient, and give barbiturates to patients.
Correct.
To control the patient, completely. So this is actually a little bit more aggressive approach, but I think, in my view at least, and Navras, you can add definitely, I think it's the right approach in any patients if they are still seizing after the 2-3 trials of the first or second line agents.
Yes.
I don't know. What do you say, Navras?
Yes, doctor. I mean, I completely agree with you, because even for the anti-epileptic, if you start them, they need at least 15 minutes to be as a duration for infusion, because you cannot give it as bolus.
Yes.
So I mean, some literatures, I mean, maybe in the American guideline, they go for more aggressive approach. Okay,
Yeah.
We know this patient that he seized multiple times without regaining consciousness. And
Yes.
this patient is status epilepticus. So maybe we could proceed directly with the intubating the patient and put him on infusion post-intubation, such as Midaz or Propofol. But however, when you read other literature, they still, go for, conservative. But I feel like, I would do the intubation earlier in time for such patients.
Yeah, I agree with you. I mean, there is no, let's say the different approaches from the different societies, actually, the recommendations, guidelines comes differently. Some of them a little bit more aggressive, some of them a little bit more conservative. But at the end, as we discussed, if it's one seizure, let's say more than 5 minutes, or in between the seizure, if the patient doesn't awake any, so we should consider this patient status epilepticus. And
Yes.
when you consider the patient status epilepticus with the low Glasgow Coma scale, and the majority of the aggressive approaches says that go and intubate this patient and paralyze and give the barbiturates and try to control the seizure. By the way, it is so strange actually. We are not able to do that much in the ED, but other recommendation, when you actually intubate, sedate and give the anti-epileptic agents, anticonvulsant, let's say, agents to this patient, which is in this case, I prefer the barbiturates more. But they said continuous EEG monitoring is necessary still, because maybe patient will not, show you any muscle contractions, extremity movements, or whatever, but it can be still subtle situs epilepticus activity in the behind, because you paralyze the patient, you don't understand the brain activity.
Yes.
So therefore, the EEG monitorization can be start as soon as possible to understand what's going on, really. Of course, in the meantime, you're still evaluating the patient, or at least after your evaluation, EEG could be applied to any seizing patient who are intubated and paralyzed. All right, let me see. Other thing. Okay, in any seizing patient, when the CT scan is necessary, there's a debate about it, but I think is that any first seizure definitely require a CT scan, especially in the adults and elderly patients. And any different type of seizure definitely, get benefit from the CT scan. But at the end, what we are looking for the CT scan, it's a kind of mass lesion, maybe abscess, or maybe, let's say, intracranial hemorrhage. So therefore, in the primary survey and secondary survey, there should be a clue somehow to warn you about doing the CT scan. I think somebody calling me, Professor Fikri is calling me, but I'll call him back. So therefore, please pay attention to your primary survey and secondary survey findings and patient history, of course, and symptoms. And then in your differential diagnosis, if anything actually scratching you and you're going to think about some pathologies that you can see in the CT scan, then the CT scan is a must for that patient, definitely. All right, and I'm going down from my note. All right, another thing, after you find the CT scan abnormality, which is in this case, intraparenchymal hemorrhage, can we see the CT scan one more time? All right, so again, there are multiple recommendations about the CT scan and the intracranial approach to intracranial approach to intracranial hemorrhage after the CT scan. So do you think this hemorrhage more than 3 centimeter by 3 centimeter?
Yes.
As a size, yeah. For example, if it is more than 3 centimeter by 3 centimeter size, a lot of recommendations and guidelines says that this patient require the surgery immediately in the operation theater. Another thing, if the CT or patient shows any brainstem compression, which is in this case, we saw the shift of the midline, and we saw the anisocoria in the primary survey preferably, but you catch in the secondary survey, which is a good sign again. So those patients, they say they benefit from the immediate surgery. And of course, any other intracranial pressure findings, which is altered mental status. One of them, maybe optic sheet, diameter increasing is another, finding. Something like this, or in this case, Cushing, for example, triad. So all these cases requires immediate intervention in the operation theater. However, it takes time to send sometime patient to the operation theater. So therefore, you need to do something earlier. And as you discussed, you can prefer the mannitol, you can prefer, hypertonic saline, and also elevating the patient head side. These are all effective measures. If I remember correctly, I remember I read one paper, maybe 15 years ago, and in their cohort, they checked the 1 dose of mannitol in the intracranial hemorrhage patients, how much volume that one dose of mannitol decrease from the intracranial volume size. They found that maximum, I mean, the volume, this mannitol treatment actually decreased, it's 120 milliliter. Can you imagine? I mean, 120 milliliter volume drain to the intravascular environment after just one dose mannitol is a huge decrease of the pressure inside of the brain. So please don't delay it. I mean, if you see those intracranial increase findings, I think these drugs are really works, along with your elevation of the head, of course. So the positioning and this pre-operation measures are really may help to the patient. Another thing, repeating the vital signs, I think, is kind of important in this case, because the patient is seizing, and you check the vital sign, and you recognize that there is an increased blood pressure. And it was a very nice suggestion, actually. Can we decrease the blood pressure? Can we manage the blood pressure in this case? And it was amazing discussion happened between you guys. But I just want to ask you one more thing. At the beginning of the patient presentation, could you please calculate the mean arterial pressure for this patient?
Is it 117?
Correct.
I didn't calculate it, but probably it's supposed to be somewhere.
Yes,
What is the
117,
equation?
Doctor.
Okay, what is the equation you calculate? I mean, how do you calculate the mean arterial pressure? I think the answer is correct. I didn't calculate it, but it's supposed to be somewhere around that level. You calculate with 2 times diastolic plus, systolic divided.
Systolic over 3. Yes, Doctor.
Said 117.
Yes.
So now I want to open another, area. So general recommendation, as the Dr. Navras said, beyond the 200 millimeter mercury of the systolic blood pressure, it in the most cases 220, and beyond, above the 150 mean arterial pressure in any intracranial pathology patients. So you have to consider immediate, intervention, which is, the treatment. It can be maybe labetalol, it can be maybe nitroprusside, because this time it is a emergency and hypertensive emergency situation now, which can cause intracranial bleeding, it can cause a stroke, which can cause, let's say, the aortic dissection, whatever you say. But above the 200 or 220 millimeter mercury in systolic, and above the 150 mean arterial pressure levels should be warn you to treat this blood pressure immediately. So if it is blood pressure more than 180 in systolic, if it is the mean arterial pressure more than 130 millimeter mercury, then you have to understand that is this patient has any intracranial pressure increase. So which is Alger-Mantel status, anisocoria in this case, yes. So then if the answer is yes, then you need to intervene again. But if there is no intracranial pressure increase in any patient, I think you need to calm down and do it gradually without really critical intervention. So the goal is, if you think this patient needs treatment, so your goal is to reach the mean arterial pressure to 110. in most of the cases, your systolic blood pressure end up with, as the Dr. Naura says, 160 level or something. So use your mean arterial, pressure calculation and aim to reach 110 if you think this patient has very high levels of the millimeter mercury of mean arterial pressure, or if it is more than 130 plus intracranial pressure increase findings on the patient. So then you can manage your treatment with your agent you gave already. Of course, the propofol, for example, is a hypotensive agent. Barbiturates, for example, hypotensive agents. And you're paralyzing the patient, they help actually decrease the blood pressure anyway. And also, now you're thinking that to intervene the labetalol, another beta blocker, for example, to decrease the blood pressures, but your goal is reaching the 110 mean arterial pressure. So that time you can stop. All right. You can balance your treatment somehow. So let me see my note. All right. One note for the ECG. I think it was a good discussion. I think every hemodynamically unstable patient, in this case hypertensive, I think it was tachycardic, right? Is it? Yes.
Yeah.
I think that any hemodynamic unstable patient needs ECG. Seizing patients definitely needs ECG, as the Dr. Naur has already mentioned and highlighted. Some toxicologic agents can cause hypertension and also cause ECG abnormalities, which is one of the specific one is the tricyclic antidepressant overdoses. They widen the QRS, they increase the QT interval. So these findings are important. So therefore ECG is a must. But any other clue you can find in the ECG in any intracranial hemorrhage cases, for example, I mean, maybe it can be another learning point for you. Just go for and check ECG findings of intracranial hemorrhage. One of the commonest finding after the tachycardia, I guess, the deep ST depressions in the lateral leads, chest leads. And if you see 45 years old lady, no cardiac history, altered mental status, and in the primary survey, in the D, you find some kind of neurological abnormalities, and somehow you stop the seizing in a couple of minutes. And when you check the ECG, and if you see the deep ST depressions, I think you automatically think about the intracranial pathology now, directly, which is very obvious finding. So I think it can be another, things to check for you guys.
Yes.
Yeah, I guess.
Also, if you don't, can I add something, Doctor?
Yeah, sure. Yeah, go ahead, please.
So there is also another thing in the ECG. They call it cerebral T waves. Maybe
Yep.
for a student also they can check it out. Sometimes also it's associated with the increased intracranial pressure along with the ST changes. So it is. That's why also maybe to consider ECG in patient with altered mental status or seizures. I feel it's very essential.
Yeah, and also differential diagnosis of the any seizure patient, as we see in this case, even regardless of they have a seizure or epilepsy history or not, all the differential diagnosis list you listed in this area is very, very important. I mean, electrolytes, low sodiums or magnesiums or low glucose and the uremia, this type of metabolic things can cause seizures. So it's always better to check all these abnormalities in those patients. Of course, the case is not really standard epilepsy or standard, the seizure case, but there are other approach you need to know about the patient seizing, and you stop the seizing, and patients totally normalized, and what to do next. So maybe you can go and search for this one a little bit more, which is the more common practice. Yeah. That's all. I think this is all my notes to add, and I really enjoy the case, how it's run, how our students actually capable of catching all abnormalities and interventions. And I think from my side, I really enjoyed and nicely done. And I think the Nauras, you guys choose a very nice case. Thank you very much for involving
Thank you,
me
Dr.
to this
Alpar.
discussion.
Thank you for your feedback, Dr. Alpar, and comment on the case as well. I think you all already summarized all the objectives. Again, I feel that now should be very clear for the students. You tackled all the, critical action that were missed or needs to be done. And maybe for you guys, for the student, if you want more information, you can read about it or review it again. And if you, of course, if you have any question, you can ask now or ask me later if you want to inquire about the case further.
Thank you, Dr. Alper and Dr. Nauras. I think you covered it very extensively, and it's a very interesting case. And of course, our discussants, I really think you guys did a really good job in keeping the conversation going. And alhamdulillah, I think it was a very successful case. So if our floor doesn't have any question, I think we can end it here. And inshallah, it's not gonna be our last ER case, inshallah. So does anyone have any questions? Okay, so I think we can end it here. So thank you, everyone, and inshallah, we'll see you next Saturday. Thank you.
Thank you very much. And thank you, Dr.
Thank
Alpar.
you very much.
Thank you, Dr.
Thank you
Arif
very
and
much.
Dr. Nauras. Thank you.
Thank you very much. Enjoy the rest of the day.